Welcome to today's topic in the webinar series, Hypertension and Atrial Fibrillation, a risky couple, even more when the family expands. And today, Professor Osman will present to you atrial fibrillation, the importance of risk factors, identification and modification. Professor Faisal Osman is working at the University Hospitals Coventry and Warwickshire, NHS Trust in the UK. He is a consultant cardiologist electrophysiologist with a special interest in all aspects of cardiac electrophysiology and ablation, atrial fibrillation, SVT, atrial flutter, tachycardia, and ventricular arrhythmias.
Thank you very much indeed, Professor Bax, and hello everybody. It's a great pleasure to join you here today from the United Kingdom here in Coventry. As Professor Bax has highlighted, I'll be talking about the importance of risk factor identification and modification with regards to atrial fibrillation. These are my disclosures. So we know that the ESC guidelines have very comprehensively given us a framework on which to base the management of atrial fibrillation on. And in fact, Professor Bax was one of the members of the writing committee. And these comprehensive guidelines are actually very, very helpful and actually underpin how we look after our patients with atrial fibrillation. And they were last updated in 2020. We know that the prevalence of atrial fibrillation is high, particularly in the Western world. It is the commonest arrhythmia that we come across. We know that it increases, the likelihood increases with increasing risk factor burden, and age, of course, is very, very important. And the older one becomes, the higher the risk of developing atrial fibrillation. And we know that we have an aging population. People are living longer, and so therefore the incidence and the prevalence of AF is set to rise. And one startling way of seeing it is that if there are 3 people in a room who are over in their 50s who don't have atrial fibrillation, there is a 1 in 3 chance that one of those will end up getting atrial fibrillation, and that's certainly very, very significant when you think about it, and certainly put things into context for me when I first heard about it. Now, why is AF important? I think we're all aware of the problems associated with atrial fibrillation, which can be symptomatic or asymptomatic. We know that AF is linked with an increased risk of death, of mortality. We know that there is a significant risk of stroke, of LV dysfunction and heart failure. We're also recognizing more and more the link with cognitive decline and vascular dementia, not to mention impacts on quality of life, depression, recurrence admission into hospital, having hospital admissions. And in those that are symptomatic, it's important to control symptoms. But equally, those that are asymptomatic, in a way, there's more risk because the AF isn't being detected. And yet these patients can continue to be at risk of their atrial fibrillation and the complications of atrial fibrillation, particularly stroke. So a very, very important condition that we need to make sure that, that we keep on top of. In terms of the guidelines, there is a clear need to modify lifestyle risk factors. The ESC guidelines very nicely point out the importance of identifying and managing risk factors in concomitant diseases such as hypertension, and it's now a class 1 recommendation from the ESC. And modifying unhealthy lifestyles and targeting specific therapies is also very, very important in terms of improving AF burden and improving symptom control. The guidelines also now talk about opportunistic screening of AF in hypertensive patients as a class 1 recommendation. And in patients who have sleep apnea, obstructive sleep apnea, it's now a class 2A recommendation. Of course, the importance of body mass index and weight is also now been highlighted. And you can see from this slide that a class 1 recommendation is also now in place for ensuring that patients lose weight, particularly those who are obese or overweight and those who are planned to undergo atrial fibrillation ablation. The lifestyle and risk factor modification is also highlighted in the American guidelines, the AHA statement published in Circulation very recently. And you can see that it's very similar. Their pillars of AF management are very, very similar to the European Society of Cardiology. And lifestyle and risk factor modification is a major pillar of AF management when we're looking to assess and optimize these risk factors for AF. And a number of studies that have been done that have looked at this have indicated that there are important impacts when you modify AF risk factors, including weight reduction, on the AF burden and the AF incidence. Now, we know that atrial fibrillation and hypertension, of course, are very keenly linked. The whole title of this webinar links to both of these as relatives or cousins. We know that 1 billion people are affected by hypertension worldwide. Stroke prevention is a top priority everywhere, and certainly here in the UK. And we know that the combination of atrial fibrillation and hypertension is very significant and significantly raises the risk of stroke. And we now also have emerging technologies that patients and members of the general public can use. This is one such device, the Omron Complete device, which is a 2-in-1 device that measures blood pressure and also a single channel ECG recording that can be taken at home very easily. It involves downloading an Omron Connect app, which patients and public members can very easily do. It uses a LiveCore technology for the single channel recording. And we recently performed a qualitative study on this, looking at both patients coming to the arrhythmia clinic and members of the general public, and it was very well received, and we'll hopefully try and present that shortly. So we also have some very, very good European Society of Cardiology guidelines on the management of arterial hypertension, and it's absolutely critical that we ensure that our patients with AF are treated in terms of hypertension, that we think about hypertension, and then use these guidelines to treat them appropriately to ensure that they're getting optimal management of their hypertension. This was a nice study published looking at alcohol and abstinence of alcohol for atrial fibrillation from Australia, published in the New England Journal of Medicine a couple of years ago. And this was a multi-center randomized control trial looking at 140 patients with both paroxysmal and persistent AF who were in sinus rhythm at the onset. And these patients were randomized to complete abstinence for 6 months from alcohol versus a control group. And the study showed a clear reduction in AF recurrence, which was highly significant, as well as a reduction in the median percentage of time in AF during follow-up. And this was using either pacemakers or ILRs or extended period of monitoring, again, highlighting the importance that alcohol plays in AF recurrence. Again, there's a lot of good evidence now of the impact of moderate regular exercise and the beneficial impact on the incidence and the recurrence of atrial fibrillation. And all of these studies that you see on this slide suggest that moderate regular exercise actually can be very beneficial compared with no exercise or with high intensity exercise. And I think we're all realizing as a community that excessive exercise and high endurance exercise may actually not be so benign that we once thought. Now, here in Coventry, we are about to start a study that we're doing. It's a randomized control trial looking at the impact of cardiac prehabilitation, rehabilitation, and patient education for risk factor management on outcomes in patients undergoing first-time AF ablation, and it's called the CREED-AF study. And the idea is that we will approach all patients who are listed for a first-time AF ablation, be that paroxysmal or persistent. We will do some baseline demographics, some health quality of life questionnaires, and a baseline cardiopulmonary exercise test. They will then be randomized into normal treatment, which is standard of care, versus the CREED intervention arm. So this will involve patients undergoing a period of prehabilitation. So prior to their AF ablation, they undergo a short period of exercise, 2 to 3 sessions a week for a period of about 6 to 8 weeks. Both groups then have their AF ablation, and the intervention arm then have a further period of rehabilitation of gentle moderate exercise, with further questionnaires about quality of life taken at around about 10 weeks after the ablation procedure has been done, with a repeat assessment of cardiopulmonary exercise testing. And the hypothesis is that with good management of their risk factors, with a good level of moderate exercise being taught to patients, their outcomes would hopefully be better in the intervention arm. And this is intervention that can be delivered by any healthcare professional, allied healthcare professionals, nurses, as well as doctors. So generally speaking, would be hopefully cheap, very effective, and easy to deliver. We're also hoping to look at more longer-term outcomes at 12 months to see if there are any differences. We'll be looking at AF burden with 7-day Holter monitors and repeating again that particular investigation and looking at also MACE in terms of rehospitalization and recurrence of atrial fibrillation. So this study hopefully will be starting shortly and it's been funded. Looking at obstructive sleep apnea, again, increasing realizations that this is a very, very important condition is closely linked to atrial fibrillation and is one of the important risk factors that we always talk about. This is a study that we're currently undertaking here. It's funded by the British Heart Foundation and by Medtronic. It's a study that is looking at patients who have obstructive sleep apnea but do not have atrial fibrillation diagnosed, but who we don't really know what the incidence of AF is within this cohort. So these patients are randomized. There's 100 in each arm to standard care once they've been diagnosed with sleep apnea versus the intervention arm, which is a loop recorder, injectable loop recorder, and a 24-hour Holter monitor. And we're hoping to try and for the first time get an accurate assessment of what is the incidence of AF in this cohort, who clearly seem to have a higher prevalence of cardiovascular morbidity and mortality. And this often is despite treatment with CPAP. The Holter monitoring will also give us an idea of assessment of cardiac autonomic function parameters using heart rate variability and heart rate turbulence. And we're hoping to try and study some vascular biomarkers also to get an indication of how things are progressing and seeing if we can get some insights in terms of mechanistic things, which will allow us to identify exactly who may benefit from further monitoring when they have sleep apnea. Now, we also know that patients who have atrial fibrillation, there are certain patients who benefit from an AF ablation procedure. Myself and many other electrophysiologists spend a lot of time in the cath lab ablating primarily around the veins to try and get durable lesions to seal the veins in. A lot of evidence that if you ablate around the veins and electrically seal them, you can improve outcomes with AF. And that can be done with a number of technologies that you can see on this slide, and they include radio frequency ablation, as well as cryoballoon ablation, where we freeze around the veins, and also the emergence now of pulse field ablation, which will be coming in the next 6 to 12 months, I'm sure. And all of these do the same thing. They allow us to ablate tissue around the veins to seal them off, and we can often ablate elsewhere as well. And we've shown and others have also shown that this is we can do this as a day case procedure, and it's very safe and cost effective. However, no matter what we do, if we're not tackling the risk factors, then actually, in terms of the outcomes, we know that we're not going to be positively impacting the outcome in terms of AF for the patient. And this is also a very nice slide that's, again, been taken from the ESC guidelines, highlighting that everything we do is patient-centric and patient-orientated with the patient at the top. We obviously want to optimize things like stroke prevention, rate and rhythm control, but actually, a big foundation of all of this is lifestyle modification and patient education and patient self-management. And along with that, educating our healthcare professionals about the importance of these factors for these patients. And often there's a psychosocial element, and certainly in the CREED-AF trial that I briefly mentioned, we have a psychologist who I think will be very, very helpful in terms of helping us to modify and change the lifestyle behaviors that can often lead to negative impacts in terms of AF recurrence. It's all good and well asking somebody to stop smoking or to reduce their alcohol intake, but you have to have measures in place that will mean that patients will persist with that and continue with that, realizing the importance of those factors longer term. So in summary, I show again these slides from the ESC guidelines, and I make no apologies about using all of these slides. They are excellent, and credit to Professor Bax and the entire team for drawing up these guidelines. But again, this highlights the importance of the patient being at the center, the number of healthcare professionals that look after these patients, including nurses, general practitioners, cardiologists, electrophysiologists, and the patient's family and carers. And it's about working with those people that look after the patient and hopefully to try and improve outcomes. And again, the CC to ABC approach, I'm sure many of you are very familiar with this, But one of the foundations, the C, is tackling comorbidities and cardiovascular risk factors in terms of managing these patients and the importance of tackling those. And one slide that I think we may just have shot past, which I'm going to leave you on, is the actual risk factors that we look at when we talk about managing these patients. And again, this is also taken from the ESC guidelines. And you can see there are many things here that we can't necessarily impact. So aging, our genetics, our ethnicity, male gender, we can't change those at all. However, there are many things, many factors that we can positively impact. And hypertension, as you see, is on there, very closely linked to atrial fibrillation, good control of diabetes and those that are diabetic, ensuring that there is good physical activity, moderate regular exercise, which links with obesity and being overweight, where we know the outcomes are worse even after an AF ablation. Smoking and alcohol, of course, are very important. We've touched on those. Sleep apnea, that I've briefly touched on, and the importance of recognizing sleep apnea as a risk factor and looking for it. And of course, also dyslipidemia as well. So these risk factors, I think, are very important. And we always try and improve our AF ablation procedure. And I think we're doing fairly well ensuring durable lesions. But the key thing is to ensure that even once we've done an AF ablation, that these risk factors we tackle, both in those that have AF ablation or even are treated medically, because these risk factors really are the foundation of ensuring good outcome. And on that, I think I'm going to hand back to Professor Bax. Thank you for your attention.
That was a phenomenal lecture, really spectacular, as I'm used to hear from you, but it was really great. So thank you very much. And I got two questions coming in for you. So the first question is, how can we convince patients to alter their lifestyle risk factors? For some, it is easy, but if we talk about, let's say, quitting smoking or losing weight, these are not the easiest ones. So how do you convince the patients that they should change their lifestyle risk factors?
That's an excellent question, Jeroen, and a very hard one to answer, I have to say. What we've learned is that the one thing that we need when we're talking to patients to convince them is time in clinic. And if we have a busy clinic where we're seeing 20, 25 patients in a 2-hour window, to spend the time speaking about AF, speaking about how we're going to treat them with drugs or with ablation, and then on top of that, also talking about the importance of risk factors, we know that we're already going to be running out of time. And I think the one thing that we have to do with our patients is take them to one side almost and spend time with them. And what we tend to do here in Coventry and what we are planning on doing with our CREED AF study is to have a healthcare practitioner, and it doesn't have to be a doctor necessarily, somebody who's trained appropriately, who knows about risk factors, can spend some time with patients, can speak to them and give them literature and highlight the importance of losing weight, which is not easy to do. You're absolutely right. It's probably one of the hardest things to do, to stop smoking, to reduce or stop alcohol intake. Again, these are things that have an element of addiction associated with them, and they're very hard to just do overnight. However, with appropriate support, you can tackle them, but it takes time. And I think it's important to have a healthcare practitioner who can sit with patients, listen to them, listen to their concerns. Literature and education is passed on. And at the same time, there's also perhaps a psychologist who may be at hand to help as well, because very often, in terms of reducing alcohol or stopping smoking, things like hypnotherapy perhaps or psychotherapy can help. And these are all very, very important. And it's, as I say, it's all good and well to try and improve what we do in terms of interventional things and look for new antiarrhythmic drugs. But these more simple things that we can do, that are more holistic things, I think are very important. The other thing also just to touch on is the emergence of weight loss interventions. So again, we had very good surgeons here at the hospital, and one particular surgeon who has a specialist interest in weight loss interventions, and with endoscopic procedures using gastric balloons. People who have very high BMIs, over 35, 40, 45, can often be candidates for these balloon procedures where patients have a balloon that's passed into the stomach, that's inflated, and that can often lead to feelings of patients being very full. Weight loss then occurs quite rapidly, and we've seen some very, very good outcomes. So I think these are all things that we have to think about, and we have to then really spend time with the patient to convince them that that actually these are the right things to do for their own sake and for their longer term outlook. But again, very, very challenging. They're not easy answers.
Agree with you, and probably motivation is one of the most important drivers. So the other question that I had for you
Absolutely.
is how can patients best monitor their risk factors? On the one hand, this should not become totally obsessive. At the same time, it's important that they monitor. So how do they best do that?
Again, another very, very good question. I think 10, 15 years ago, I don't think we would have been, in a position where we could get patients to monitor their own heart rhythm, for example. Over the last 10 years particularly, there's been a great advance. I also have an iWatch, an Apple iWatch that I'm wearing, which monitors my heart rhythm. Whenever I want to do an ECG, I'm able to do it. And increasingly, there are more and more devices out there, wearable or stick-onable, that can actually allow you to monitor your own heart rhythm. The Omron device that I talked about, that we did a small study on, is a nice one because it allows patients to monitor not only their blood pressure, and those have been around for a long, long time. And again, not in an obsessive way. I'd certainly take your point, Jaron, on that. It's very important that patients don't start obsessing about these things. But if they are regularly or regular intervals monitoring their blood pressure, and at the same time can take a quick tracing of their heart rhythm, I think that puts them in a very powerful position because they have a lot of data which they can then show to their clinician, to their GP, their cardiologist, and actually the cardiologist or the healthcare professional can then make some judgments based on actual hard readings that actually, yes, the blood pressure is well controlled, yes, you're in sinus rhythm, yes, you may have had some symptoms, but this is not atrial fibrillation, or this is atrial fibrillation, and we need to think about doing something. So I think this embracing of technology, and again, we and others around the world have looked at these technologies and how we can try and embrace them. It does generate a lot of data. And of course, there is a risk that patients and members of the public might become a little bit more obsessive in terms of looking for these things. But I think overall, I think that there's a great potential for benefit. And I think patients clearly can monitor their weight in terms of alcohol intake and smoking. They clearly also can be motivated to try and reduce those. They can keep an eye on those. And I think hypertension is another big one. So if patients have some way of monitoring their blood pressure, because very often hypertension is completely asymptomatic. So somebody can have high blood pressure, be on therapy, but actually be completely symptom-free. So monitoring and using technology to ensure that they have good blood pressure control is very important. So I think, in short, embracing the technology that is available to us, that will develop, I'm sure, even more, and we'll have even more metrics that we can look at, but at the same time, not obsessing. I think it is important. You do make a very, very good point. We don't want to create a culture of hypochondria where everyone is checking their pulse every single minute of the day. It has to be a balance, but I think we can get that balance, and I think the modern technology is there to help us, and I think we should embrace it.
Yeah, I fully agree with you. On the one hand, we should avoid that they get obsessed, but at the same time, if they see that they are adhering to change in lifestyle risk factors, that they feel that they're doing okay. So I think that is important. They get a confirmation that what they suffer, so to say, what they cannot do, that it translates into a reduction of the severity or extent of number of risk factors. So I fully agree with you. I want to thank you for this great lecture and the discussion we just had. And thank you again.
Thank you. Thank you very much indeed. Thank you.